Okay, thanks. I cannot hear y'all. I don't hear anything. Should I start? Okay, thank you, sir. Thank you, Chairman Watson and Chairman Kirkpatrick. For those of you who don't know me, I am a pediatrician whose practice focuses on behavioral health, specifically autism, complex ADHD, and anxiety. My patient population is about 75% Medicaid and comes from over 65 counties. And the number one reason I see a new patient is evaluate for autism. My team provides diagnosis, medication management, parent training on behavioral interventions, ABA therapy, counseling, educational advocacy, and chronic care management. When my patients need a service and we can't find it available in the community or in our part of the state, then generally we try to add in that service. And that's why I added chronic care management, educational advocacy, ABA therapy, and counseling over the last 5 years. Behavioral Pediatrics of Rural Georgia serves the population that is at risk for hoteling. Many of our patients are foster children, but many are not. On just last Friday, a mom called us in crisis. Her 6-year-old son had threatened their in-home ABA therapist with a knife. After mom secured all of the knives and explained to him that his behavior was unacceptable and what the consequences would be, he told his mom that he would just find another way to scare her off, her being the ABA therapist. Of course, the ABA therapist didn't want to return, and he basically got what he wanted. But he wasn't even the only patient of mine to brandish a knife at an adult last week. And if either of these kids was in foster care, they would both be at risk for hoteling, because they certainly are not easy to place, easy to manage, and their families worried about family members' safety as well. When I think about the root causes of hoteling for foster children, 3 things are really obvious for me. The first is the lack of a full and comprehensive diagnostic evaluation. Hotel children often carry the labels of oppositional defiant disorder and ADHD. And all of my patients who are in foster care who have been hoteled had undiagnosed autism at the time that they were hoteled. There are very few clinicians diagnosing autism across the state, but autism affects 2% of Georgia's children, according to CDC data. And the number of foster children is much higher. Many times the psychiatric evaluation that is done of foster children is done by a licensed professional counselor, and LPCs are not qualified to evaluate or diagnose for autism. And the reimbursement for autism evaluation by a physician is pretty low. DFACS has difficulty providing providers for their foster kids, and the AmeriGroup 360 program doesn't really facilitate those referrals. I've had several children who had court-ordered autism evaluations for many months before they were ever even scheduled for an appointment. The second obvious problem is lack of early intervention. And we all know that early intervention is very cost effective. Babies can't wait, preschool intervention, early Head Start. The challenge is that many of those providers don't get very much autism specific training, and reimbursement for challenging cases is the same as for easy cases. So who wants to sign up to take care of a child who bites and spits and kicks and hits all day, every day, until they learn how to effectively communicate in other ways? It makes it very hard for the difficult children to be placed and get services. So the third big problem is that crisis intervention services are rarely available. All of our state has access to the Georgia Crisis and Access Line, but my families report that often no one actually comes to do an evaluation, or they come more than 6 hours later and their child's already asleep at that point. Often families are told that they should call law enforcement, but law enforcement doesn't have any training on how to manage those situations. And if the child is directed to the emergency room, then they just sit in the ER and wait for a crisis stabilization bed to become available, which sometimes takes days. But the sad part is, if you get a crisis stabilization stay a week after you get out, generally you're not much better than you were before you went in. So in just the last 7 days, my office has gotten several calls from families that are in crisis. And this just gives you the big picture. A 6-year-old with autism who hits his family members anytime he's frustrated or told no. Mom is afraid that DFACS is going to be called when the 4-year-old goes to pre-K because she has so many bruises all over her. Mom wants me to see this 4-year-old's body so that I can document that she contacted me and she's worried about this because it looks like her child was abused. And in many ways she was, by her older brother who's 6. I suggested that the little sister be sent to grandma's house for safety, but that's not a reasonable long-term plan. And if these kids were in foster care, that's not how things work out very easily. You can't just send one off to grandma. Another child, a 5-year-old with autism, who killed the family's kitten by closing it up in the pull-out couch. He said he wanted to know if the cat could get out. He was sad and remorseful that he killed the kitten, but he didn't really understand that this could occur until after it happened. A 9-year-old with autism and depression who continues to set fires inside the family's home. All the lighters and matches were secured, locked away. They were not any inside the home at all. So then he used the electric stove to set paper on fire that then he moved to the trash can so the fire could spread. A 9-year-old, the school says that he can only attend school for 3 hours a day because he's too dangerous. His ABA therapy was stopped when his family had to file for bankruptcy because of medical cost. And he was thriving when he was getting appropriate services. He wasn't even in a special school for children with behavior problems. But now the school staff invades his personal space if he doesn't comply within 30 to 60 seconds. And he views that as aggressive and he responds with aggression. These are just a few examples, but all these things happened in the last 7 days with current active patients of mine. And if these kids were in foster care, they would have likely ended up in a hotel, or they would have gotten an evaluation to see if they needed residential psychiatric treatment. For the children who don't have DFACS as their guardian, that's even harder to access. So it's really quite challenging. Potential solutions to reduce hoteling: improve accessibility for autism diagnosis by increasing the reimbursement for the procedure codes that are billed during autism diagnosis. That's 96112 and 96113. Currently, reimbursement for those codes and the amount of time required is lower than reimbursement for an office visit that required that amount of time. So there's no motivation for additional pediatricians to learn to diagnose autism and bill those codes. Second potential solution: invest in care coordination by local providers. Unfortunately, the care coordination that goes under the AmeriGroup 360 program doesn't really trickle down to assist primary care providers and pediatric specialists or foster parents that are seeking referrals or access to specialty care. When I request data that should be available from paid claims data by AmeriGroup, what medications have they paid for? What specialist has this child seen? Has this child had a hearing test? And if so, where? I'm unable to get any data at all. Only once in the entire time that I have worked with AmeriGroup 360 have I actually gotten data. The third thing is for foster children in crisis, let's flip things around just like it is for emergency surgery. Instead of having to do a prior authorization before you can get services, do the prior authorization after the services. If they're not deemed medically necessary, then the guardian, which would be DFACS, is on the hook. But when you go to the emergency room and you need emergency surgery, there is no prior authorization that has to be done beforehand. It's all done after the services are provided. And if we treated behavioral health emergencies the same way, then children wouldn't languish while they're waiting on a prior authorization. Our fourth solution, evaluating if managed care is actually cost effective for foster children. The goal of managed care is cost savings. That's why it's being managed. It's really managing the cost of care. And fee-for-service Medicaid has the goal of providing access to care with children with disabilities. Why can't foster children be served with the goal of creating access instead of the goal of reducing cost? I suspect that if you increase access and reduce barriers, that you'll actually reduce the overall cost, because kids will get the services they need and they won't end up in crisis quite so often, and they'll have greater stability of placement. And then they won't be harmed in the meantime while they're waiting on a prior authorization. Medicaid fee-for-service now contracts with private practice, LPCs, LCSWs, and psychologists. You know, more ABA therapists take fee-for-service Medicaid than take any of the Medicaid CMOs. And quite a few ABA therapists only take fee-for-service Medicaid and no CMOs and no private insurance. It's the biggest network as far as access goes for ABA therapy is through fee-for-service Medicaid. The Amerigroup network is actually narrower than the fee-for-service Medicaid network for my patients. And the last potential solution is spend the resources currently used for fighting denials to pay for recruiting providers to care for and serve our foster children. That could be, the healthcare providers could be done through loan repayment or simply adding a modifier so that reimbursement when you provide care to a foster child is higher than reimbursement to a child that's not on foster care. And there are already some modifiers to be able to do that for well child visits, because it doesn't matter when the last when the last well child visit was. A child who goes into foster care, it should get another well child visit within a certain number of days of entering foster care. So the technology and logistics for that probably already exist. And to make it where it's much easier to not spend all those resources fighting denials would go a really long way.
I don't think Dr. Zena can hear us, so.
I can hear you.
Oh, you
now,
can. I'm
Dr.
sorry. Our so our IT technology snafu is improved. So does the committee have any questions? All right, Senator Orrock, you're on. What's your microphone? Okay.
Thank you, Mr. Chair. Thanks so much for your compelling presentation and your to kind of a voice from the trenches that's dealing with these tough realities that you described to us. Just to drill down a bit on one thing, that this idea of spending the resources that are currently put in doing denials, spend those resources, redirect them to where?
Well, if we reimbursed providers who are serving children in foster care at a higher rate, then providers would be highly motivated to serve those children.
And you don't, I don't expect you to have any idea of how much resources, someone else in this room knows what resources we're currently spending on denial process.
I'm quite confident that DFACS can provide some data on that.
Thank you.
Anybody else with questions? Well, maybe we do. Okay. Senator Mallow is microphone 11. Thank you.
Thank you, Doc, so much for being here. I just had a quick question. Would the state having greater oversight on the CMOs help address some of this denial that exists by the state being able to look at who's being denied and maybe get more in the weeds with those CMOs that are denying the long-term care for juvenile patients?
I think that would make a difference for all children right now. If there is a problem with any CMO, a physician or whoever the healthcare provider is can complain to the Department of Community Health. But CMOs are kind of in limbo because they're actually run by private insurance corporations. And there's always been some gray area that they fell in between DCH and what the insurance commissioner's office does.
Thank you, Dr. Zena. Any other questions from the committee? All right. Thanks so much. Appreciate you scheduling out there. I know you rearranged your schedule. Thank you for helping us understand it. And we appreciate what you do. And you can get back to seeing some patients and help take care of them. Thank you so much.
All right. Thank you so much.
Next on the agenda, we have Brian Pedersen and Audrey Brannon from Department of Human Services. I was trying to think what's going to be the easiest way logistically, maybe the podium. Is that okay?
You're chairman.
Yeah, right. Yeah. 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 The podium mic is on already. So if you don't mind helping us understand your position a little bit better, and we're going to, I said we're on a 10 to 15 minute time frame. If you need to go less than that or a little bit more, we're good. But we really appreciate y'all being here and help lay out the framework for us. Thank you.
Thank you. So good afternoon. My name is Audrey Brannon. I'm a licensed clinical social worker. I've served with the Division of Family and Children's Services in a variety of roles for 21 years. I'm really grateful to be here today, and I have some prepared remarks. And then, of course, if anyone has questions, I'm happy to answer them. A little over a year ago, I accepted a position focusing solely on complex care youth who were hoteled or without an appropriate placement. This work is high cost and very low success. It's tireless. It's days filled with begging for somebody to ensure a child's needs are met. And everyone saying, no, we don't have a bed. We won't approve that service. We cannot accept that kid. My passion around this topic has gotten me in trouble more than once. And today that may happen again. And I'm okay with that. I hope that my words do not fall on deaf ears and that this information leads to some change in our state. So today I'm going to outline a few case examples to give you an idea of what we're facing in child welfare. An 11-year-old girl entered foster care in August of 2022. She was abandoned because following years of trauma, abuse, then adoption. Then her legal guardians could not control her unsafe behavior or meet her mental health needs. Less than 30 days from our initial involvement, she was legally ours and in foster care. From a crisis stabilization unit or a CSU, we placed her with a foster parent, where within 12 hours, she had smeared feces all over a bathroom and attempted to jump out of a window. She went back to a CSU for 10 more days. 1 month later, a request was submitted to AmeriGroup for psychiatric residential treatment, or a PRTF, and it was denied. She was hoteled for a month as we looked for placement. She was in a CSU once during that time, and then went back to a CSU from October 29th to November 14th. Then she spent one night in a foster home where she was banging her head on a wall, hitting herself in the face, tried to electrocute herself, ran into a pond to try to drown herself, and then swallowed a pair of earrings. She was then in an emergency room for 5 days where she had very similar behaviors. She defecated and urinated on the floor and tried to throw it at staff. She was hitting and biting. Eventually, she was readmitted to a CSU from November 22nd to December 2nd. And at some point, AmeriGroup did approve PRTF for her. Since that time, She was at a hotel for 11 days, a CSU for 7 days, a hotel for 4 days, a CSU for 8 days, a hotel for 4 days, CSU for 4 more days, and then back to a CSU that very same day because she had suicidal gestures again. And that's where she's at now. We cannot get a comprehensive psychological assessment done because there is no AmeriGroup provider available to do such testing. And we can't get her into a PRTF despite the approval because no one will accept her or they say they're full. Another female youth who was adopted at age 2 from foster care re-entered foster care in October of 2021 when she was 13. She had involvement with the Department of Juvenile Justice, had multiple stays in crisis stabilization units, threatened her mom with a knife, drank rubbing alcohol, and was constantly cutting and injuring herself. Again, less than 30 days from our initial involvement, her adoptive mother was fearful for her safety and abandoned her to state custody. We requested that the judge require the adoptive mother to work reunification services. This request was denied. So the mother was absolved of any requirement to engage in services with us or with her child, whom she had parented for 12 years. We were able to get this child into PRTF for treatment in the beginning of 2022. She stepped down in June, and within 60 days, there were 6 calls to the Georgia Crisis and Access Line due to her self-injury, suicidal threats, and aggressive behavior. A PRTF was submitted to AmeriGroup on September 26th, and it was denied. We appealed, it was denied again. And then on November 4th, just 4 days later, she took 11 of her lithium pills and cut herself with glass. She was taken to an ER, and then once medically stable, she went back to a CSU. She was self-harming and swallowed a battery while she was at the CSU. She then went to Children's Healthcare of Atlanta on November 16th, then to a CSU. She was headbanging. Then she swallowed another battery. So she went back to CHOA. On November 23rd, she was at a 3rd CSU. She swallowed a marker cap, had to be restrained, and again, swallowed a battery, had to go back to CHOA again. Meanwhile, our AmeriGroup PRTF appeal was pending. On December 20th, AmeriGroup reversed their decision, and yes, she is now approved for PRTF, but there are no beds available. She since swallowed 4 batteries at one time and had to go to CHOA again. She's been denied by 5 of the 6 PRTFs in Georgia, and as of this morning, we still did not have an option for her, and so she sits at a CSU. A 3rd youth, a boy this time, is 12. He was in a hotel for 30 days, went to a PRTF from September of 2021 to April of 2022, where he was administratively discharged for assaulting a PRTF staff member and damaging property. We sent a case manager to pick this child up who was too violent and too aggressive for a locked treatment facility. From April to August, he was in a hotel at a cost of over $186,000. He destroyed multiple hotel rooms, was exposing himself, breaking mirrors, threatened to kill people, threw a lamp, damaged cars, busted windows, and was taken to an ER 3 times and then released because no CSU would accept him. On July 31st, he was detained after hours of destruction of property, multiple law enforcement calls, and he was cutting and threatening to stab people. He was charged with terroristic threats, simple battery, and destruction of property, and he was in YDC. While there, he was on special management. He was smearing feces. He was threatening to stab other youth. He was cutting himself and self-injuring. And the mental health community has said he does not qualify for a CSU or PRTF because it's behavioral. That system will not serve him. The Department of Juvenile Justice had a competency evaluation done, and he was deemed incompetent and non-restorable. So that system won't serve him. He's 12. On January 5th, he was released from YDC to a hotel. He was in a hotel for 5 days. He went to the emergency room because he was screaming, hitting walls, and threatening to kill himself or someone else. On January 12th, back to a hotel because no CSU could be identified. On January 13th, in the emergency room, again, because he ran into oncoming traffic and said he wanted to die. He was in 4-point restraints and medicated just so the emergency room staff could manage him. I personally reached out to the GCAL leadership, and they, along with a very large hospital affiliate, searched for a CSU for him desperately. None would take him. So he discharged to a hotel, and that's where he is right now. He currently is with 3 behavior aides, and they are barely able to keep him safe. Our standard hotel costs are for 1 behavior aide at over $1,000 per day per kid. So 3 behavior aides triples that expense. One final youth, another girl, also abandoned to foster care in April of 2019 after she spent 8 months in a PRTF, but showed little progress and was still threatening to kill her mother and her infant sibling. When she entered foster care, she was in 5 different foster homes in 1 month because her behaviors were so unmanageable. During 3 months in the summer of 2020, she spent 8 days in a group home. She had 6 CSU admissions. She was admitted to PRTF for 3.5 months. They felt like she'd met her treatment goals. She was discharged to a foster home where she stayed less than 5 weeks. During 6 months in the spring of 2021 and summer of 2021, she spent about 5 days in a group home, 7 days in a hotel, had 7 emergency room visits, and 6 CSU stays. In August of 2021, she was arrested at a hospital in an ER for attacking hospital staff. While at YDC, she had 4 self-harm incidences. She was released to DFACS in February of 2022, and the state funded a PRTF for her at a cost of $72,000. She stepped down to a group home again in August, and between August 4th and November 19th, she had 3 CSU admissions and created such a disturbance with other youth at a group home that she was arrested, charged with aggravated assault, criminal damage to property, all felonies, and detained. On December 8th, she attended a court hearing and she had self-inflicted injuries and was sent to a CSU, where then on January 8th, she was released and she went to a hotel. Since that time, she's been in 2 emergency rooms and is now in a CSU again. We expect she's going to be released and we'll start that cycle all over. Her therapist submitted a PRTF request and it was approved by Amerigroup. But 25 PRTFs, both in Georgia and nationwide, have denied her. And I'm not confident that we're going to be able to locate appropriate treatment. So if those 4 cases leave your heart heavy, and I'm sure it does, I have 453 more to tell you. That's the number of youth in foster care we've had to hotel so far this fiscal year. So we're only halfway there. This is why our staff quit. We are here to protect children from their caregivers who may be maltreating them. We are here to provide resources to prevent maltreatment. And we cannot do that when so many of our resources, both staff and financial, are trying to plug the holes in our healthcare system. It's like using your index finger to stop the leak in the Titanic. With me today is my colleague, Brian Pedersen, who leads a new team designated to review and represent any youth in foster care who's being denied medical services. We have a team of people now, all experts trying to navigate this system, and we're failing. Me, I do this for a living. I've done this for 25 years. I'm an expert. I'm also a clinician. I can't navigate it. So this is not a DFACS issue. This is a system issue, and it has to be addressed as such. Brian, if you want to talk about the appeal process.
Could we do one question first, Chair Lady here?
Yeah, my question for you is on the PRTF placements. I keep hearing that a lot of our PRTFs there's a high percentage of kids from out of state that are filling those beds, which leads to the beds not being available to Georgia kids. Have you seen that? Do you have a sense of that?
I have heard that, and I know that we have recently seen an increase in out-of-state kids being placed at certain PRTFs. When I ask them why, as I've worked with these people a long time, they don't generally give me a solid answer. I don't know if it's about reimbursement rates or if there's some other issue.
Thank you. Yeah. Have a follow-up here. Mike, number 5.
I think it might have been the first child you were talking about, but you talked about the judge denying it. Could you expand on that a little bit? Was this a juvenile court judge? Is it typical? What's the reasoning? How does that work?
Yeah, so it was a juvenile court judge. And typically when kids enter foster care, we request reunification services. So what we want to provide families. The mother was adamant. She did not want those services. She did not want to be obligated to work those services. And we advocated to provide those and at least force some responsibility for both her and the kid, right? The kid needs hope and needs to see that. But the juvenile court denied that request, and it's currently a non-reunification case plan.
Thank you, Mr. Patterson.
Thank you, Chairman Watson, Chairwoman Kirkpatrick, and committee members for the opportunity to testify to the State Joint Committee or Senate Joint Committee today. My name is Brian Patterson. By profession, I am an attorney at law. I've been actively licensed and practicing law in the state of Georgia for almost 21 years. I am the Assistant Deputy Commissioner at the Georgia Department of Human Resources, and I have the honor of serving under the leadership and direction of Commissioner Candace Brosh. I have worked at DHS since May of 2022. In my current role, I lead the Office of Health Law and Policy. And one of my office's core responsibilities is to represent any foster child or youth who has had their request for medical service or treatment denied by the Georgia Family 360 CMO AmeriGroup to ensure that they receive the medical care and treatment that they are contractually obligated to receive and that is medically necessary or federally required. Every day, my office will review all medical treatment denials, and we will file appeals if we determine that such treatment is medically necessary for the child or the youth. The first step is an administrative appeal to AmeriGroup. If the coverage denial continues to a final denial, we file a request for a fair hearing with the Office of State Administrative Hearings and conduct an administrative hearing. Since I've arrived at DHS, our priority has been ensuring the medical treatment for the most medically fragile children and youth. This group includes children and youth who are experiencing severe mental health emergencies to such extent that they are a danger to themselves, their siblings, host foster families, and other children within these residents. These children and youth need immediate help, which can only be rendered by having them get inpatient psychiatric residential treatment, something that in my office we call a PRTF. The PRTF provides intensive residential treatment for foster children and youth whose emotional and behavioral issues prevent them from living safely within the community. Since I've been at DHS, I have personally reviewed and witnessed these extremely medically fragile children and youth being routinely and systematically denied medically necessary PRTF treatment. Regardless of the child or youth's medical circumstances, they will all receive the exact same formulaic denial notice. Even when a child or youth is provided treatment, the CMO will seek to discharge the youth or the child from the PRTF at the earliest possible time, even in circumstances where treatment is determined by a medical professional as medically necessary. And yes, we also appeal the discharges too. Since August 1st of 2022, my office has forced 31 cases to be referred to the Office of State Administrative Hearing for a fair hearing. All of these cases involved PRTF initial denials and PRTF discharges. In addition to PRTF appeals, my office has recently begun processing medical treatment appeals. And medical treatment is non-PRTF medical treatment for foster children and youth who are insured under the Georgia Families 360 plan. Examples of medical treatment can include routine medical treatment such as dental treatment, sedation, fillings, braces, fluoride treatment, crowns, prescription drugs, physical medical assessments, mental health and psychological mental assessments, evaluation, and treatment. The number of denials that my office receives daily from what I term medical treatment far outstrips the amount that we receive for PRTF. My office has a lot of appeal work ahead in this area of medical treatment, but I can assure you it will make the PRTF numbers that I just gave you pale in comparison. In addition to PRTF and medical appeals, my office also works to get treatment for other medical issues that is contractually obligated to provide for foster children and youth. My office has determined that there are no current inpatient substance abuse treatment options available for any foster children and youth. Medical treatment problems of foster children or foster children and youth do not arise just when the need for treatment arises. We have also discovered that these children and youth are not being medically serviced from the time that they enter into state custody. Based on federal Medicaid guidelines, the state of Georgia is required to provide comprehensive services and furnish all Medicaid coverable, appropriate, and medically necessary services needed to correct and ameliorate medical health conditions. The state of Georgia meets this requirement via the early and periodic screening, diagnostic, and treatment, EPSD for short, and something that I believe Dr. Zena was referencing. This is supposed to provide a comprehensive and preventative healthcare service for children under the age of 21 who are enrolled in Georgia Families 360 Medicaid plan, including children in foster care. EPSDT is key to DHS's role to ensuring that children and adolescents in foster care or in the custody of the state of Georgia receive appropriate preventative dental, mental health, development, and specialty services. Pursuant to this agreement, AmeriGroup is to ensure that all initial EPSD health and screening visits are performed as appropriate for all newly enrolled Georgia Family 360 EPSD eligible children within 90 calendar days or within 24 hours for the birth of a newborn. Additionally, we are supposed to, as a state, maintain a compliance of 80% on all these children within 90 days. As of September 28th, 2022, a review of the figures supplied by AmeriGroup showed that there were 2,621 eligible children in foster care and the custody of the state of Georgia who have not had EPSD screenings. Most of the affected children had been enrolled in Georgia Families 360 and EPSD eligible for at least 90 calendar days. Additionally, the data showed that we are failing to maintain the minimum compliance with screening percentages as required by federal rules.
Mr. Patterson, if we could wrap it up.
Sure. Mr. Chairman, the main message of my testimony here before the committee today is that the current system in place that we use to provide medical treatment for the approximate 11,000 foster children is not meeting the needs of the most vulnerable citizens. These children and youth's current access to medical treatment, be it routine, specialized, or federally mandated, is falling far short of our obligation to these children. Additionally, not only is the current system detrimental to the healthcare needs of the foster children, but the current system does not benefit the citizens of the state of Georgia as it increases DHS's overall expenses that are used to expend and fill the gaps in coverages that taxpayers already pay for.
Thank you so much. Appreciate that. No, that's a tough job that you both have for 22 years. 22 years. Questions from the committee? Pretty quiet. Okay, all righty. You're number 10, Senator Ora.
Yeah, thank you, Mr. Chair. Thank you all for service that you're providing above and beyond. It's my understanding that there's been an effort to really step up legal intervention in this situation, and I think it'd be helpful if you gave us a quick overview of that, because there's a real effort being made to hold the feet to the fire on these denials and pierce through, as this is what I understand. You correct me if I'm wrong.
No,
But to pierce through this denial ruse that we're seeing from provider, from people from entities that are supposed to be covering the costs. But we have really lawyered up as a state to try to secure these services and bust through that denial screen. Is that accurate, or clear that up?
That is accurate, Senator. The purpose of that is that the individuals that are in the field, the case managers that service these children daily, are overstretched. They do not have the simple bandwidth capacity to handle appealing all of the appeals that they have to deal with. And in order to make the rubber hit the road, this is what our agency has been forced to do.
Costly thing. I mean, attorney's time does not come cheap, and nor should it be. You're highly trained in the law, but we're spending loads of money on that. I think the point was made by the doctor who first testified from Statesboro. If we could figure out moving that battle on these denials over to services and higher reimbursement rates, would be smart to look at that.
I would agree.
Thanks, Senator. Any other
Thank-
questions? Senator Burns, number 9.
Can you enlighten the committee on the denial rates and the reasoning for denials? As a percent or as a,
Well, how about this, Senator? As far as the denial rate, the correspondence that I receive are only the denials. So I can only
can't-
fill you in on one side of the equation
okay,
with regards to denial rates.
okay.
As far as the reasonings, as I highlighted, when I first came in, it was a very systematic form letter, the same for every child, regardless of, Ms. Brandon gave 5 different scenarios, okay, but they all got the exact same denial letter for treatment with the exact same reasoning given.
And placement continues to be an issue too. Senator Jackson, got you.
We're gonna hear more about that. Yeah.
All right, thank you.
Thank you.
12.
Thank you, Mr. Chairman. And thank you both for the service that you do to try to protect Georgia's children. Just briefly, so you gave us 4 different scenarios of children who are still quite young. What happens to children who are in this similar circumstance who age out of care for DFACS? Where do they go? When do they end up in prison? I think is probably my ultimate question
Yeah.
here, but can you tell us how that works out?
Yeah, and we try desperately to keep those kids in foster care. They can stay in foster care up to 21, and then we usually extend past 6 months. And we try desperately to convince them to do that, but it's voluntary. And so we try to transition them to adult services through our local community service boards, through, if they're on probation, Department of Corrections, and then of course through DBHDD to support our, youth with developmental disabilities or other pervasive mental health issues.
Thank you. Senator Estevez. Had a question.
Thank you, Chairman. Thank you all for your work. 2 quick questions. Mr. Pedersen, to piggyback off of Senator Orrock's question, are there any experts helping you with these appeals to assess whether they're medically necessary on top of what you're receiving from the medical practitioners?
Well, internally, I mean, we have our own staff like Ms. Brannon, social workers, and medical experts, but as part of any appeal, we're also consulting the outside medical professionals that have recommended such treatment in the first place. And we're not just appealing it without consulting with them to ensure that the underlying cause is medically necessary.
We're running out of time for questions, but Senator Walker, you got a quick question?
I don't know if it's quick, Mr. Chairman, but
All right.
Ms. Brannon, you
Sorry.
gave us a case history on 4 very, very troubled young people or children. Heartbreaking story. And one of them, I think you said the YDC would not even, the Youth Detention Center, juvenile jail would not keep them. Is that correct?
Correct.
So what it sounds like to me, the hoteling problem, part of it, a big part of it is there's actually no appropriate facility to house these children. And has there been any kind of study or plan or discussion about the state actually building or repurposing a facility to house these extreme cases? I know the federal government wants us to have folks in the community, and that's the big push, and that's understandable, but clearly these children don't need to be in the community.
I think there are appropriate facilities for these youth. It's that these facilities are choosing not to serve them when it comes to our PRTF and private facilities. As we've kind of stated, they have plenty of business. So they don't need to serve the hardest kids, which is what Dr. Zena kind of pointed out. When the reimbursement rate is the same for a kid that's super, super hard and in foster care, which creates additional hardships for the providers, they're not choosing to serve our kids. When it comes to, YDC, they are, of course, have legislative limits around how long they can detain a kid.
Well, can I follow up real quick?
Please, that
Sorry,
was
Chairman.
good. That was a good question. Thank
So-
you. Didn't mean to cut you off.
So if a YDC can't handle the child because they're a danger to themselves and others, I'm just not getting how what is a appropriate place? I mean, should the state build or figure out a way to house these very, very troubled children? And why has there not been a plan brought forth to do that?
I think that's a great question. And that's part of the reason I'm here today, is because it is a system problem. Our healthcare system can't serve them. Our, Department of Corrections and YDC can't serve them. And there's a lot of kind of passing of the ball. Mental health facilities will say it's behavioral and this kid needs punishment. And YDC will say this kid has mental health issues and needs mental health treatment and we can't serve them. And so then they come to us.
All right, thank you.
Thank you, Chairman of Insurance. That was a very good question. Thank you so much. All right, I'm sorry, the chair lady has a question.
Very quick, I think. Of the foster kids that we have in Georgia, I was intrigued about the reunification process and how that works with families, not in extreme cases, obviously, but where there's some possibility. How many of our foster kids are legal orphans that don't have a possibility for returning to a family?
I do not know that information, but we can get y'all that information. We try really hard practice wise not to create legal orphans unless we have an adoptive resource.
Thank you for that question also. All right, thank y'all. Thank you, number one, for what you do for these children. And again, you're right. That's why we're here, in more ways than one. Judge Render Hurd, yes, Judge Hurd. I'm sorry, at juvenile courts in Tifton Judicial Circuit. We hope, we'd love to hear from you. Thank you. If you wouldn't mind giving us a little bit more background and And thank you for being here. If you came from Tifton today, we hope you survived the rain
I
and
barely did, but we did. Thank you for the opportunity to be here. I am Render Hurd. I am the judge of the Tifton Judicial Circuit's juvenile courts. That is Tift, Turner, Irwin, and Worth counties. Have a 4-county circuit. I've been the judge of those courts for almost 11 years now. Prior to that, I was a special assistant attorney general representing the Department of Family and Children Services. Prior to that, I was a parent and child attorney and guardian ad litem. I've been doing some form of child welfare work for 25 years-ish. And so am familiar in this area. And so I am also currently the president of the Council of Juvenile Court Judges. So I appear here on behalf of the council as well. To give you some information, I do want to piggyback off the last speakers in that I do believe this to be a systemic problem. I do believe there are issues with regard to private providers who both won't provide services or unwilling to provide services for the reason previously mentioned. There are other reasons. I'll give you a couple of anecdotes. I have a child that was hoteled last year out of my circuit for almost 5 months. He came in as a delinquency child after having been arrested over the weekend for beating his mother to the point that it put her in the hospital. He was a severely autistic child. He was incompetent to stand trial in a delinquency case. And so his mother, who had been trying to get him services and was extremely involved in his life, weighed about 90 pounds, and he weighed over 200. He was about 6'1". He was 16 years old, profoundly autistic, predominantly nonverbal. And he had an issue with anger management in which he would lash out. On the night he was arrested, the mother awoke to him standing over her bed. He had had some kind of dream, felt as if she was the cause of whatever nightmare he had, and he was standing over her with some object hitting her. And so when he was detained over the weekend, on Monday, we were, this was during the pandemic, late 21, when this first came about. And we quickly realized, I mean, we're on a Zoom hearing, and he doesn't, I mean, obviously understand what's going on, is basically nonverbal, making, sounds, but not speaking necessarily. However, was not threatening to kill himself, was not threatening to kill anybody else, had simply, woken up from a nightmare and had this issue. So we quickly realized that he didn't need to be in the RYDC at that point. He has the mentality, and there's some question about this, but, they guess somewhere about an 8-year-old maybe, and he's 16. And so he obviously couldn't go home, however, because we were worried that he, in the next case, might kill his mother, and not out of meaning to, but because he didn't understand what was going on. Fortunately or unfortunately, when I ordered him out of the RYDC, he tested positive for COVID. And this was during a time when we were still, that was a major, not that it's not a major issue now, but, they were concerned about it to the extent we could not even find him someone to sit with him in a hotel because they were worried about, being exposed to COVID. So he did remain in the RYDC. They actually wouldn't release him because he was quarantined. To show you the level of child we're dealing with, the RYDC allowed his mother to bring his set of puppets to him, so that while he was quarantined by himself in the RY, he had these puppets that would assist him and keep him calm. And so they actually brought puppets in the RYDC. Now, he was, the one good thing about that is he was quarantined. He was safe from himself at that point. He was safe from others. And he remained there under quarantine for a week or so until we could get him out. but that left us with no option then. During that time, the district attorney filed a Chins action on the ground that this had happened multiple times, and the mother contended that he was habitually disobedient to the lawful commands of his mother. So on that basis, he filed a Chins action, and in an effort to assist him, his attorney did not make the same incompetency argument in the Chins case.
Judge, we use a lot of medical terms, but you just use.
Okay, I'm sorry. I apologize. A child in need of services, which is another type of case that we deal with. Predominantly in the juvenile court, we deal with delinquency cases, which are cases where a child has committed what would otherwise be a criminal offense. Dependency cases, the child has either been abused or neglected by his parent or her parent, or Chins cases, which is a child is in need of services, having committed what we call status offenses, and sometimes running away is a common one. Another time, another kind of Chins case is a habitual disobedience cases. Truancy and habitual disobedience and runaway are the three predominantly types of Chins cases. In this case, we were able to establish a Chins case. Part of the disposition, part of the things I can do in a Chins action. And this is one of the issues that we're going to be dealing with over the next few months with regard to this is in a Chins action, a parent does not have to abuse or neglect a child for me to place that child in the custody of the Department of Family and Children Services. One of the dispositions available to me for a child in need of services, and this is debated, but this is the current state of the law, is that I can place the child in the department's custody as a means of obtaining the services needed for the child, if I find that the child can't be served in the community, and that there are no less restrictive ways in order to assist that child in the community. In this case, obviously, by this set of facts I've given you so far, there was no other way. So I placed the child in the care of the Department of Family and Children Services. And he spent the next 4+ months in a hotel with 2 providers who were there to make sure that he did not have another violent episode, that he did not act out, or he did not cause harm to anybody else or to himself. During this time, they're looking for a placement. As they were discussing, the 2 speakers who spoke before me, they were searching for a placement. All the placements that we could find that could address his autism could not address his aggression. All the placements that we had that could address the aggression could not address the autism. And they searched and they searched and they searched while he did actually quite well, believe it or not, didn't have any problems, didn't give any problems. So he's staying. Of course, he's nonverbal, and so they're dealing with that. They're getting some educational services, but all this at a tremendous cost. Ultimately, a placement was located in Texas. He is in Houston, Texas, in a Devereaux treatment facility specifically for autism. And I just checked with my case manager while I was waiting at a per diem of $1,169 a day. All right. And we don't have that type of facility here currently. And so that's a high level issue of a case where a child is not quote unquote bad, and he has major mental health issues, but who doesn't qualify for PRTF in the classic sense, in that he's not trying to kill anybody and he's not trying to kill himself. He just has more mental health issues that can be addressed at the time. The other major area, and since I'm limited on time, I'll limit it that we're having to deal with is kids who are habitual runaways. They're nonviolent. They're not committing crimes necessarily, but they are running at every time that we place them somewhere. And those kids are also, as I've said, children in need of services, can be declared children in need of services. One of the things that we can do in that circumstance, after we've tried other things, is to place them in the custody of the Department of Family and Children Services, at which time they run. Believe it or not. Okay. They run from home. They're certainly going to run when they're placed with strangers. The law does not currently, the current state of the law does not authorize me to detain a child for runaway for longer than 24-hour period. So child runs, I get them back and I can hold them for 24 hours, or I can order that they be held for 24 hours. We have a continued custody hearing and then they must be released after that, which time they go right back and run again. Well, as you can imagine, they're not a list of foster homes who say, hey, we're ready to be here and be a foster parent for somebody who's going to run in 5 days and may take our car with her or with him when he or she goes. And so we don't have foster placements that are willing to take those. After they've run several times, the congregate care facilities, the group homes will not take them. Just like the speakers before me were talking about, very difficult to get those kids placed. In the extreme situations, when the children figure out that, hey, if I just run, they're going to put me up in a hotel. Okay. And they're going to feed me Burger King, McDonald's, and Chick-fil-A if I want it, because if I throw a fit bad enough, then that's what I can talk however I want to the person who's with me. I can cut. I mean, I've had them tell me, Judge, I've never been cussed like I was cussed in the hotel room. Okay. And there's not a good placement. We don't have a lot of options. Now, I will say we don't order kids as juvenile court judges. We don't order kids into hotels. We place children in the custody of the department, and then it's the department's responsibility to find an appropriate placement for the children. However, at this point, especially for these type children, they don't have a lot of options, to be honest with you. And we have major issues with this. I will say one of the major issues with the runaway is the trafficking of girls who are being trafficked. They run. And I will tell this, I had a 14-year-old that I was dealing with, and I said, you can't run. You'll be out on the street. How are you going to feed yourself? And a 14-year-old looked at me and said, oh, I can feed myself. I promise you. And I said, no, you can't. You have no way. She says, no, I have a commodity. That was the word she used. Never forget it. She said, I have a commodity and I'm not afraid to use it. And so we have a large number of girls who are running from these placements. We can't keep them from running. We don't have adequate placements for them, and they're on the street and they're being trafficked, quite frankly. And it's a sad situation. So I do agree that it's a systemic problem. We have to develop some placements where we can both serve these, because she doesn't need to be in the RYDC. I mean, in that situation, she's not committed a crime, but we also need to protect her from herself, from, committing, being run away and being trafficked. So it's a very delicate balance, one that I don't have a lot of answers for, even from us. And we're supposed to be the experts, okay, because it's very difficult.
We much appreciate that. Thank you for what you've been doing. We have a question here, Senator Brass and then Huffstetler.
Thank you, Mr. Chairman. Judge, you mentioned, we don't have a proper placement here. Are there other states out there that do have proper placement? And if so, what is a proper placement for someone like that?
So, and that's a good question. Okay. One that, I don't know, like I said, right now, the hoteling is the only option they have. Okay. Right. And so, we definitely need to have a study done we need to look into what kind of placements are available. I know in my autistic child situation, they did have a placement available in another state that was available. And we had exhausted, I think at one time they had made over 250 referrals in this state for that child. And none of those places would, and in this state and the border states as well. So I don't know where the placements are. That needs to come from a social child welfare side of things.
A quick follow-up, Mr. Chairman. Do you know, was the place in Texas, was that a private facility or was that
It is a private facility.
It is. Okay. Thank you.
It's Devereaux,
Okay.
but it's a special facility. I think they have 10 autistic kids in the entire facility.
Got it. Thank you, Judge.
Very specialized placement.
Hi, Judge. Thanks for being here. It sounds like you've got a good circuit, and my retiring judge, Greg Price, who I guess is a rarity in being directly elected, I think does a great job up there.
He does.
But
he's also my predecessor. So
all right. He's great. But one component, I know we're talking about all the extreme cases, but is resources and beds and all that. In some other areas, I've had reports of guardian ad litem's that just don't have the reports ready in time, and it's delayed for a couple of months, then they come back and they still haven't made the visit. I've had families complain, said they just didn't show up, whether we're trying to adopt or reunify or whatever. And this can go on, a year. And then I even know one example where they said, well, now I've got a conflict and the process started all over again after a year. So my question is, we've got a commissioner who we want to reduce the numbers and be able to have resources in other areas. But I don't think anybody is accountable to her. So in these situations, who are they accountable to?
So us, in some respects, the Council of Juvenile Court, the individual juvenile court judges who preside. However, one of the things that we run into is another resource thing. Most of the circuits outside of the metro area, certainly, I'm down in Tifton, we have individual lawyers who serve as guardian ad litems. I have, thank goodness, a fabulous CASA program. The CASA program from a guardian ad litem standpoint is invaluable to us because those people are volunteers. They are 100% committed to those kids and they get their reports in. I don't have that issue that you described there. But ultimately, and this is what happens if you only have one attorney who will do that in your circuit because you don't have enough resources to pay that attorney and they're late with a report. From a due process standpoint, you can't just say, well, I'm not going to take a report. The law says you have to have a report. So it creates issues, again, going back in some respects to funding. And if it's hard for a judge, and I will just say this, and I have not been put in this situation, I've just heard anecdotally, it's hard for a judge to say, well, I'm not going to use that person anymore because he or she is less than diligent in their work when that person is the only person who is volunteering to do that kind of work. And part of that's the pay issues.
It's a challenge. You're good. Any other questions from Senator Mallow? You're on mic 12, I'm sorry, 11.
Thank you, Mr. Chairman. Just a quick question for you, Judge. I know that when we were talking about hoteling children today, but I do remember a few years ago, might be longer than 10, the state used to place children in emergency style group homes. And then there was a push to stop placing children in those group homes to try to provide them with a better sense of home. And then we went to some other models and now it appears that we're hoteling those children. Any reason why we are maybe engaging in the hoteling practice of children from the courts instead of maybe placing them in some of the group homes, family homes that have been built to serve children kind of in that emergency space?
Absolutely, because those almost all of those providers are private providers, and they're private providers, and they can decide whether they want to take a kid or not. And so there are different levels of these providers, and this is a good way, or I try to look at it. And there's certain providers who take low-level kids. Let's say kid is 1, which means the easiest, has no problem. 10, ultimate, my autistic, child, and there's certain placements take, and I'm just making up these numbers, but let's say that they take 3 to 5. Okay, children who are 3 to 5s. Well, if you're in that facility, it takes a lot less to provide for a 3 than it does a 5. So they've got 2 beds, okay, and you've got a 5 that comes in, and they say, well, I'm not going to give up this bed because tomorrow there'll be a 3 coming. Okay. And so, and they're making, and they're private, for-profit, places. And so they are certainly entitled to do that. And so we say, hey, will you take our kids? And they look and no, they don't say it this way, but he's a 5 and, or he's a 6 and we're not going to take him. We don't wait for a 3. And so that's sort of the way. And you can imagine how many people are wanting to take a 9. Okay. They're very, very few.
All right, thank you. I think we've run out of time on the questions and we still have a couple more presenters here. Next, thank you so much for coming, and a lot of respect for what you're doing there. Appreciate you leading the juvenile courts there. Mike Dudgeon, someone known to most of us, if not all of us, a face around the Capitol for
Long time,
12 years.
12 years.
Yes,
But we came in together as freshmen at
We-
Ice Storm 12 years ago.
we did. That's right. Freshman in high school. I like the way you said that. That is a way of looking at the House of Representatives there. I hear you. And a.
Well said.
Okay.
I did
okay.
come over here to the Senate for a while to hang out with you guys.
Yes, we appreciate that. Thank
And-
you. As a parent, a foster care parent, you're here and I know you've studied this issue. Would love to have your insight.
Yeah, so I'm here to tell you guys a story. It's really a sad and tragic story in many ways. You've already heard parts of it today. And as the chairman mentioned, I've got 3 hats on. As a former legislator, I've sat in those chairs. I've been a foster parent for a while. And also for 3 years was a policy director for Lieutenant Governor Duncan, in which this was an area of focus and foster care. So I've got 3 perspectives. And before I get started, because it's going to be kind of harsh, some of the things I say, I want to extend a little grace to my friends here from AmeriGroup. Being an insurance company is hard. It's easy to beat up on insurance companies. Everybody does it. My grandfather was a senior manager for a pharmaceutical company, and everybody, drug companies are taking all the money and everything like that. So I just want to extend a little grace here that everything is harder. A lot of these challenges we've heard about are very difficult. There are not a lot of easy answers. That grace being extended, I think there's some serious issues that I want to lift up to the committee today that hopefully we can work on. So, and again, I'm glad this is a health committee, not judiciary, because I'm not sure what I'm going to say would pass the lawyer test, but I think it's pretty strong. And I'll say this way, when there's smoke, there's fire. I think I've got a Mercedes-Benz stadium full of smoke. So my story starts in 2016 when I was leaving the house and my wife and I felt called through our faith to become foster parents. We went through all the process and got certified. And since that time, we've taken care of dozens of kids, most of them on a part-time or respite basis. And so I've lived this thing of dealing with foster kids and healthcare from the trenches as a foster parent. So I saw it first from that aspect before I looked into it from policy a little bit later. When you're dealing with foster kids, you heard some very extreme cases. None of them have easy stories. And you talk about what's going on with their parents, it's all sad. All the kids who end up in foster care deserve every bit of empathy that we can give as people here at the state. So we got these kids and we found very quickly that I live in South Forsyth County near the intersection of Gwinnett, Fulton, and Forsyth County. I can't drive by a traffic light without seeing doctors' offices. There's medical stuff everywhere. But we found very quickly, though, is that we're trying to use AmeriGroup for the foster kids. It was very hard to find a provider. The network, at least, was very tough to find it. So several times my wife and I would just, because we could afford to, we would just pay for it ourselves because we didn't have to deal with it. One particular very sad case, it had a girl who had been sexually abused at age 2, who was in therapy, and wasn't more than a year or 2 after that happened when we were told by the therapist that AmeriGroup had denied continuing therapy. Again, with the doctor, everybody said yes, but AmeriGroup said no. The therapist said it was a game, that she knew some way to call somebody somewhere and do some sort of shenanigans, but the person that was her in to get things fixed was left or something. And so we went through a lot of shenanigans that eventually got settled, but we personally paid for it in the meantime. So again, that's anecdote, that's anecdotal data. That's what I saw on the ground as a foster parent, like I said, still doing it today. So then in 2019, a friend of mine from the House named Jeff Duncan, who lived a few blocks upstreet, got elected lieutenant governor and convinced me to leave the private sector to come down to be the policy director, in which case I got to work with many of you here today. And in that process, I got to know a little bit better a guy named Jack Hill, Senator, Appropriation Chair, a great guy. I knew him a little bit from the House. And I also met this incredibly brilliant, hardworking woman named Melody Debussy, who was running the Senate Budget Office, who just blew me away. And I found out she was a Georgia Tech grad, and I figured, well, now I understand why she's so smart. And so got to work with those guys because I was the representative for the lieutenant governor's office and what's called Green Door, which is sort of the big budget meeting that kind of hashes out a lot of the things. And Melody, as I came on board, she said, we got these issues going on, and one issue that we're working on is hoteling of foster kids. And I said, oh, really? I'm a foster parent. What's a hoteling? I didn't know what she was talking about. So she explained about hoteling, which we've already talked about a good bit today. And at that time in the state budget, they had spent $20 million, $10 million on direct kids in hotel, and $10 million on where the state paid for PRTF because it was denied by AmeriGroup. So this was a $20 million budget problem, but it was not the reason the appropriations people were digging into this was not strictly because it was a budget problem, it was because it's a moral problem. And so there was a working group that was trying to address this problem. And again, this was back in 2019. And so as part of that, we asked for a lot of information from AmeriGroup to try to look at this thing, but data about claims rates and denial rates and what reasons they were using for medical necessity. Are they using different terms than what the Medicaid requires, and how they were making these determinations? And we asked for this data, and we were stonewalled for months and months and months. We were asking it through DCH, because again, you know, that's who administers a contract. But it was just a total stonewall. And this was with the weight of the Lieutenant Governor's office and the weight of the Senate Budget Office behind it and the weight of Senator Hill, months and months of stonewalling. Well, we finally got some data months and months later. And I thought I'd lost the data because all my IT and emails and stuff from the Lieutenant Governor's office are long gone into the memory hole since I've left the office. But believe it or not, last night and this morning, we actually found some of the original data. And I'm going to put a big disclaimer here that this is not judiciary evidence. This is anecdotal, but it is based on data that we received at the time. So one number we got was, we said, well, what's your claim denial rate? How much is being denied? What kind of claim denials, et cetera. All we got essentially was a raw number, and it was 13%. So we said, how much, but it's 13% of the claims, but is that like 80% of the dollars? I mean, the money is really the more important number here. Would not give us information. We said, tell us what the 13% is. Is this PRTF? Is this mental health? Is it regular? Didn't get information. All we got is 13%. But interesting enough, we'd also asked about the money. Like, we knew how much DCH was paying for AmeriGroup fiscal year with a capitated rate to pay them. And we also said, what's the total amount of claims paid out? I'm gonna give you the data. Again, I will characterize the results we got. Data that we got were sort of like a hostile witness. It took a long time to get the data. It was minimally responsive, and attempts at follow-up were denied. So I can only give you what I was told. So fiscal year 18, according to the data I received, the state paid $136 million in capitated rates for the foster kids, and the claims paid were $69.5 million. Even if you assume a 15% overhead for administering claims, that would infer a 35% profit rate on this program. I don't know if that's true or not. I asked for more data at the time, with Stonewall. All I can tell you, there's a lot of smoke there that this money is not being appropriately spent. Fiscal year 18, also on the behavioral health side, $76 million of money paid, 47 million of claims. Again, it's hostile data, but it's all I had at the time. I just lifted up to you for further investigation. Another thing we asked for was network adequacy, because we'd heard a lot of things that we'd seen as parents that was hard to find a provider. And we got a big giant list of providers. And one thing we noticed right away is that, I looked in Forsyth County where I live, and there's a huge list of doctors. And what it was if there was like a big, like Emory or Children's or some Piedmont or some big facility that had one office in Forsyth County, it was dragging in their system this huge list of doctors who were associated with, say, Emory. And so it made it look like there was tons of doctors in Forsyth County who would do this, but really it was only a handful. So I questioned the value of the data. Again, look for more data, didn't get it. At this time, we had a meeting with AmeriGroup and some representatives with Lieutenant Governor. I only saw Lieutenant Governor Duncan in a meeting get angry a handful of times. One was in this meeting. We got a lot of corporate speak, and I've seen some stuff in the press about it. I still, unfortunately, seeing too much corporate speak. I hope we can move beyond corporate speak. Chairman Kirkpatrick brought up a question. Turn off my stupid phone, sorry. About PRTFs and where the kids are. During this time, I arranged to take a tour of one of our PRTFs out in Douglasville and talked to the director and said, yeah, half our kids here are from Alabama and Tennessee. Said, why? Well, said, because they pay us more money. And so we're barely staying afloat. I'm from Alabama, but it's not good to be getting beat by Alabama and that kind of thing. And so I do think it's a true statement that part of our problem with access is that we have beds that are being filled by people of that states because of reimbursement rate. So at the time this was going on, we had this working group, and everything, as you know, you guys have been around in government. Things are slow, they take a while, and the working group was working on it. We seem to be making some progress. And so, I thought we were just going to keep moving forward. And then, of course, we had COVID, Jack died, I lost my son to suicide. And so the kind of thing kind of lost the scent or whatever on this. And lo and behold, I'm now private citizen. The only political thing I do now is work with the State Charter Commission. I find out, that the new commissioner who's been there for a couple of years defects, and that this hoteling is still a problem. And I was depressed to hear that. And so when asked to come testify here, I was glad to do so. After our family tragedy resumed fostering about a year later, we do a lot of respite fostering. So we see a lot of kids and talk to a lot of parents, and at least at an anecdotal level, doesn't seem like much has changed as far as difficulty in accessing. That's all. It's just not really acceptable. But I'm going to give you my suggestions for what I think I would do if I still had a voting card in the General Assembly. We actually had drafted a couple of these bills just to play around. One would be to put the foster kids on the state health benefit plan. Let them get, if it's good enough for our employees, it should be good enough for our foster kids. One would be moving to fee for service. That way you don't have this incredibly complex CMO conflict of interest type thing keeping these kids out. We also think we have a accountability problem. Someone mentioned this. So you have Medicaid, you've got AmeriGroup, you've got DCH administering the contract with AmeriGroup, you've got DFACS, who legally is the guardian for the kids. You got too many cooks in the kitchen. No one's responsible. And it's an interagency problem, which we have sometimes here, but we need to figure out that. Maybe you move it over and let DFACS administer their own healthcare plan and just make them in charge. That way they're accountable and they can deal with it. We need rabid transparency. Transparency is good. We were looking, and Lieutenant goes also about healthcare plans. We don't have good access to data from the providers and from our insurance providers in Georgia. Our other states do a much better job at requiring data. This contract, I understand, I think is up for rebid. It was supposed to be a couple of years ago, I think, but it was being redone now because of COVID. We need to make sure that whatever contract we do for the foster kids, that the state gets the data, we get anything we want, and that we really have transparency. I think that's part of the problem. I look forward to hearing what AmeriGroup says next. I know they're going to testify. Hopefully they'll admit that there's a problem. That's your first step. Admit, and this is not all the problem. We heard some of these stories. There's also just not enough beds. These cases, which are so difficult, it's a multi-discipline problem. But there is a problem that appropriate medical care is not getting to these kids. And part of that is arbitrary denials that we've had to have a whole office set up at DFACS in order just to fight the arbitrary denials. If y'all knew, when I was Lieutenant Governor, also I had a little DEFCON sign on the wall. DEFCON 5 is peacetime. DEFCON 1 is nuclear war. I'd say that unfortunately that with these foster kids in hotels and this whole situation's been going on for too long. And if I had my sign, I put a DEFCON 1 for this issue. And I left it up. It's complex, but we've nibbled around the edges of this too long, and it's time to do something for real. Thank you.
Thank you. I don't know what to call you. I was used to calling you Mike, but
Mike's fine.
Thank you. Thank you. Does anybody have any questions? Okay, sure.
I just want to say, as a bulldog in the numbers business, I've always got a lot of respect for anybody who used to teach calculus at Georgia Tech. And I really appreciate the suggestions you brought forward, and I hope the committee will look at them.
Thank you.
Thank you. Ditto here. No further questions.
Thank you, guys.
Thank you very much for being here. I know you went above and beyond and changed your plans. Thank you so much. We have next AmeriGroup, Nick Dijon, Sam. We appreciate y'all being here, and the floor is yours. Thank you.
I don't know where Mike went, but Mike, thank you for that grace. And Mike, in all seriousness, we talked about this a long time ago, but you and your family were in our thoughts and prayers for a long time after the loss of your son. And I know that everything you're saying today is coming from a well-intentioned place and that you care deeply about this issue. Chairman Watson, Madam Chair Kirkpatrick, members of the committee, appreciate the opportunity to be here today. Appreciate y'all looking into this issue, giving us this forum to talk about how AmeriGroup administers this contract to serve our foster care youth in the state. My name is Nick DeJong. I am the Director of Government Relations for AmeriGroup. And if I may, I'd like to start with a statistic that I think highlights some of the urgency around this issue. And the time that we have been, the 8+ years that we've been serving this population, these children, our membership in the GF 360 program has more than doubled. So I think that's important to highlight because it tells you where we are trending as a state. And I think it is all the more important that we are all working together, rowing in the same direction to identify real concrete solutions that are going to benefit these kids. Because at the end of the day, I know that is what everybody in this room wants. We wouldn't be here if not for that. Got a couple of folks from our team that want to introduce today. Bhavini Solanki is a LPC licensed, I know the acronym, but I always forget, licensed professional counselor. And she is the lead, the director for our GF 360 program. Dr. Vanderlyn Sewell is our behavioral health medical director and a licensed psychiatrist. She's also an adjunct professor for both the Morehouse and Emory schools of medicine. Most importantly, though, both of these individuals are deeply, deeply passionate about caring for these kids, and they have cared for these kids. They've treated them, they've interacted with them for decades in a variety of care settings, and we're fortunate to have them as part of our team. But before we let Bhavini give an overview on this program, I want to allow our plan president of AmeriGroup, Mel Lindsay, to make some brief remarks. And again, we just appreciate y'all's time.
Good afternoon, and thank you. I'm Mel Lindsay. I'm president of AmeriGroup. Madam Chair, Mr. Chair, thank you, members of the committee.
Thank you for being here.
Thank you for inviting us. And I'll be brief because these folks.
You're good. If you don't mind getting a little bit closer to the mic and.
Okay, because these folks have much more important things to say than me. Mr. Dudgeon, in meeting with the Lieutenant Governor some time ago, he's deeply gracious in allowing us to have that conversation. I think we discussed that, and Chairman Hill, I consider to be a friend, so I certainly appreciate that. And I appreciate all of the commentary and testimony that's been provided today. This is deeply personal for me, right? I've never had anyone call me, and to the extent they will call me, and you can ask anyone who calls my number, I give my personal number out, where if there's an issue, we get it resolved quickly, and I take it very seriously. We've been serving in Georgia. We served 600,000 people since 2006, the foster care program since 2014, and we are honored and privileged to do that. I am a child, one of 9 in my family, and 3 of my brothers that God graciously brought us were brought to us through adoption and foster care. My brother Kerry, my brother Amir, and my brother Joseph. My brother Kerry has intellectual disabilities. He is the proud caretaker of my elderly mom today. My brother Amir just recently was honorably discharged from the Army, and now he works for Coca-Cola here in Georgia. My brother Joseph, who works for the county, they are my brothers. And so this is not something that's impersonal to me. I feel this deeply. I started my career working for the Illinois Department of Children and Family Services, right? So I understand what it's like to have kids who have complex behavioral needs and to be there and serve them. So I want you to know, when it comes to transparency, we stand ready. We work with our state agencies and our providers and advocates. We surround ourselves with steering committees of people who are leaders in this space, which they come here and happily share with you the things we're working with, but obviously this forum today doesn't allow for that, but we welcome that at future meetings. We sit and talk about really complex care and complex cases with DFACS on a monthly basis, right? And so again, we've been doing this since 2014. I've never made a decision about how to treat anyone, particularly a foster care kid, about that was related to cost, and I never will. Right? We will get people the right services at the right time all the time. We spend lots of time when we can't find placement in Georgia, seeking placement in other states. And we have numerous examples where we've had to do that. And so I just wanted to be here and share with you that I'm deeply, deeply committed to this population and serving to the best of our ability. We know there are opportunities for improvement, right, in the system of care, and certainly with what we do as well. And we're committed to making sure that we actually, through the folks who help us, like I said, our steering committees who inform us about how to do this better, we are deeply committed to working with them to improve the way we serve.
Thank you.
However, I want to introduce these folks because they actually have really good context. So Bhavini, I'll start with you.
Could you
Good afternoon. Thank you for having us. So my name is Bhavini Solanki, and I do serve as the Georgia Family 360 Director for AmeriGroup. I'm honored to come and talk to you today about our Georgia Family 360 program, but I would like to tell you a little bit about why this work is important to me. So as Nick shared, I am a licensed professional counselor, and I have worked at several community-based providers here in Georgia, providing direct care for Georgians, specifically youth that have been in the child welfare system. Over those years, I've completed just about every assessment that DFACS reimburses, including home evaluations for new kinship caregivers, substance abuse evaluations for biological parents, and CCFAs, which are the mandatory comprehensive child and family evaluations that are conducted for all youth coming into care. I've also completed many supervised visits for youth with their siblings, as well as youth with their biological parents. I've been to trailer parks where grandparents are trying to take care of their grandchildren. I've interviewed numerous women at the DeKalb County Jail who just gave birth to their babies while being incarcerated. And I've also seen many families reunite, grow together as a unit, and find a way to be better together. The beauty of the Georgia Family 360 program is that we are more than just an insurance company, more than just a payer. We're a group of mostly clinicians, especially on my team, who have a direct connection to the child welfare system, having worked in all of the levels of care, including many of the state divisions. We do this work because it is truly meaningful to us, and we're about real stories, real people, and real solutions. AmeriGroup has been a managed care entity, as Mel shared, for the state of Georgia since 2006. In 2014, we earned the honor of also serving the Georgia Family 360 population. This population today consists of about 15,000 youth in foster care and former foster care, and about 16,000 youth who have been adopted out of the child welfare system. This group also includes about 150 justice-involved members. As is required by our contract, all newly eligible members are assigned to a care coordinator. Our triage team is the first group to work with our members. The non-clinical side of this triage team outreaches DFACS or any guardians involved and work to get all of the initial medical, dental, trauma assessments scheduled as they address also transportation barriers with that family to ensure those appointments are completed. The clinical side of the triage staff will complete triage assessments with the member and the family, collect all the pertinent information to guide that plan of care, and link that member and family to specialty providers for further evaluation and treatment as is indicated. The triage team serves as a bridge to our targeted, goal-oriented coordination for care for our members. With the use of the additional use of the exciting new predictive analytic tool that I'll talk about in a moment, the triage team will assign members to the most appropriate level of case management after the initial assessments are conducted. This ongoing case manager is assigned based on the number of risk factors that have been collected by that triage team from collateral information and interviews. The more history, the more current the trauma, the more the diagnoses, the higher of level of case management that member will receive. And certainly that can be escalated and de-escalated at any time as things change or are known to us. Contractually, care coordination is the process of actively linking a member in a timely manner to providers, medical services, social and other support services, or resources that are appropriate to the needs and goals that are identified for that member. It is the job of my care coordination team to assist in navigating the healthcare system and coordinating with DFACS and DJJ to develop workflows, processes, and including those that are related to the transmission of clinical and non-clinical member information. Case management is a member-centric collaborative process of assessment, planning, facilitation, and advocacy for options and services to meet an individual's health needs through communication and available resources to promote quality and cost-effective outcomes. As part of this work, the AmeriGroup case management team ensures necessary appointments are made, barriers to complete these appointments are addressed, and any recommendations from these appointments are also addressed. As new programs are identified throughout the state and with our provider partners, care coordinators will make an appropriate referral into these programs. In addition to case management, Georgia Family 360 offers a great list of value-added benefits. These are free extra services and items that are offered to members above and beyond their covered services that may address their complex health needs. These can include Boys and Girls Club membership, tutoring services, gym vouchers, home meal delivery, gas cards, MARTA cards, Chromebooks, and many more. In addition to care coordination and these additional value-added benefits, Georgia Family 360 also provides several other support services. We have a robust training and education team, which includes clinical and non-clinical trainers. We are contractually required to train law enforcement officers, judges, and we have training material ready for DCH and the other sister agencies, including DFACS. We have a regular schedule of in-person and webinar sessions to fit everyone's schedule. We also have introduced more supportive events for our caregivers, such as parent cafes, so that caregivers can come meet each other, build a support network. We also offer quarterly town halls where our state agency leaders come in addition with experts and share about our various topics that are meaningful to the community. As part of our training efforts, we have worked over the past few years to also inform stakeholders and providers about the various levels of care that are available to the behavioral health services in Georgia. Outpatient services is kind of the lowest level. That includes individual, family, group therapy, skills services that are called CSI, intensive family services that are called IFE, various assessments, and then high fidelity wraparound services, all of which we authorize regularly. Next comes IOP, which is intensive outpatient services. There's not a lot of those available. And then partial hospitalization, PHP, which there definitely is not a lot available. After that comes PRTF, which you've heard of the 6 psychiatric residential facilities in the state of Georgia. And then finally, inpatient facilities, which are emergency acute settings for the most acute situations of members such as self-harm or those that are actively suicidal. Georgia Family 360 also provides a 24-hour call center where members, caregivers, and other stakeholders can call and have general questions answered. And also get connected to their case manager, as well as provide any other services that they might need, such as access to their ID card and things like that. As part of the continuum, AmeriGroup is also focused on the future employment of our members. We started an apprenticeship program in 2019 through our corporate IT teams for former foster care youth. They are hired on through a 5-year program, learning from each of our IT departments and ending up with a job promotion as a senior apprentice to whatever team they find most compatible. We recently partnered with an organization who has an internship program for production assistants with a career path into the film industry. We're in current conversations for future partnerships in the media industry and with youth being able to obtain a pilot's license. We believe that we can strengthen our ability to improve the health and well-being of our members through strong partnerships and collaborations within our community. We have regularly scheduled monthly meetings with DFACS, DCH leadership, quarterly meetings with DFACS county and regional leadership, and of course, family team meetings and staffings with DFACS and DJJ case managers, as well as any ad hoc meetings that may need to be scheduled. Another example of strong partnership is the Georgia Family 360 Steering Committee, which Mel also mentioned. This is a committee that is comprised of a diverse group of thought leaders and stakeholders across Georgia who provide advice and counsel to AmeriGroup leadership on organizational strategy, improved community relations, and informed policy and procedures.
Thank you, Ms. Saliki. We're sort of getting close on time here for the room, and we'd love to hear from our. Thank you for doing that. Love to hear from our child psychiatrist. Was that
Yes, I'm Dr. Sewell. I am a board certified child and adolescent psychiatrist. I have, prior to joining AmeriGroup, have worked in the state of Georgia for the past 20 years, treating child and adolescents. I've worked in 4 of the 6 PRTFs in this state, most recently having been medical director at one of them for the past 6 years. Experience with autism, especially, is one of my areas of expertise. So the children we are talking about, I know them very, very well. Just want to give just maybe a different perspective or an additional perspective in terms of the PRTFs and authorizations and some of those things that have been brought up. It's important to remember that PRTF is not placement. And sometimes those issues do get conflated, and we just need to be clear about that. A peer review, meaning me speaking with the provider, is offered before any denial is administered. Okay, that's a standard practice. And it is not uncommon for me to speak with my peer and they will tell me it's a placement issue. Well, what does that mean? That means the child has been at the facility, they've worked through their treatment plan, they've met their goals, and they are appropriate to step down to a lower level of care. Just this week, I did a peer review on a member with a physician who said, yeah, she was ready to go. She was scheduled for discharge that week. However, the placement they thought they had, the application had not been submitted, and therefore the bed was lost and the member was still at the facility. Another example, we talk about the appeal process. So again, a peer review is offered for any denial. I had a case that has gone to fair hearing. A peer review was offered, the facility declined. They have the right to do that. The paperwork they submitted did not identify any issues, and therefore it was felt that the member no longer met medical necessity. Time was given for disposition and discharge. That's always the case for children in DFACS. Even at denial, they're given additional time for disposition and discharge. Went through the appeal process. With the appeal, the expectation is that there's additional information given in order to consider looking at the case again. No additional information. The case gets escalated to fair hearing. Before a case goes to fair hearing, it comes back to the initial reviewer, which in this case was me, for review before it goes to fair hearing. No additional information for me to make any other determination. Move forward with fair hearing. As it's pending, we're notified that, hey, we've reached out to the facility. Please talk to the facility. They're going to provide you some additional information, some documentation, and have a conversation with you, which I did participate in and will follow up regarding that case. But it wasn't until we were at the fair hearing process that additional information was provided. So yes, there's lots of resources and efforts being put into this appeal process, but there are things that could be done earlier in the process to probably avoid having to get to that point. So just wanted to provide a couple of examples from a different lens in terms of what authorization denials look like, and open to any questions.
Thank you. Thank you so much. I think the chair lady has a question.
Yeah, I actually have a couple questions.
Mhm.
The first one is, certainly both our committees, Health and Human Services and Children and Families, are going to be meeting regularly throughout the session and probably beyond. So would AmeriGroup be willing to provide aggregated, de-identified data to help us understand this better? That's question one.
Yes.
And then the second question is, how do you measure the success of your case management? What metrics do you have in place to determine your outcomes?
So part of it is completion of visits, completion of scheduled appointments, as well as making sure that their wellness and their health is improving. And for behavioral health, right, that doesn't go on the same continuum, but that's a matter of attending appointments and making sure that their case plan is being addressed.
And the data question,
Yes. Your first question? Yes. The
you
answer is
guys would
yes.
be able to provide us with data.
Yes, ma'am.
Okay.
Thank you so much. Senator Hodges, down from my neck of the woods. Your floor, you're the.
Thank you, Mr. Chairman. I have a question, and it can be for Mr. DeJong or Mr. Lindsay or either of the clinicians, but I would ask, would you comment on the data that Mr. Dudgeon presented earlier, particularly 13% denials? Is that normal? Is that an industry norm? If not, is it high? Is it low? And then secondly, the data that he mentioned, he had a couple of years of dollars data that he spoke of, and it sounded like the money that was paid to you, about 50% went to claims. Is that about 50%? Is that normal? And
I'll say this, I think that Mr. Dudgeon acknowledged that some of this was anecdotal, so we need to look at it and verify before we can really comment on it, but let us look through it and then we'll be able to comment.
Thank you so much.
Yeah.
Appreciate that. Number 9 for Senator Burns. 8. Okay.
Just to follow up on Chairwoman Kirkpatrick's request, is it permissible for committee members to submit written questions for witnesses and go through the chair so that we can ask specific questions that we would like answers to, and that we will give you 90 days or less to respond?
The 90 days, that's a long time.
30 days.
The
10.
we appreciate that. 90 days.
90 days, yes, done.
No, we, Senator Burns,
I did. I'm glad to hear that, but I'm just saying.
I agree. So, some of that is, I mean, I know they are in a request for qualifications, and some of that is we may or may not be able to answer. But I mean, I think you can certainly send questions, and this is an open dialogue. We have the president right here.
Yeah, to your point, we are in a blackout period relative to procurement. So those things that we can respond to don't violate the procurement rules, we will respond to, right? Okay, sorry about that. Yeah, I was leaning down. I apologize for that. But again, I was saying we are in a procurement period and a blackout. And so those things that don't violate that blackout period, we can respond to. Right?
Absolutely. Thank you. Any Senator Brass, 1.
Can, number 2, I'm sorry. Thank you, Mr. Chairman. Can one of you guys or girls walk me through and give me the 10,000-foot level? How does AmeriGroup work in conjunction with Medicaid? Like when does it kick in for these kids, or is it all Medicaid? I'm trying to understand that piece of it.
Are you asking specifically for kids in foster care
Yeah,
or Medicaid?
specifically in kids in foster care, because I thought they kicked into peach care at some point, and I'm just trying to understand.
So it's when they come into state custody, then that is sent over to us in a file from DCH.
So then Medicaid kicks in.
Yes.
Okay. So let me ask this. Do you think we talk about no places for these kids, and that's what this whole meeting is about. Our IMDs out there, institutions for mental disease, for those of you who don't know, are those potential placements for some of these foster kids?
That's part of our referral list. Yes.
Okay.
In Georgia and out of state.
Okay, and I know there's a federal law that doesn't allow IMDs to draw down Medicaid. Is that accurate?
I'd have to check on that. I'm not sure offhand.
Okay, well, my understanding is that IMDs are not eligible to draw down Medicaid, is my understanding. I had a bill on this a few years ago. And so if I'm wrong, I'm wrong.
I'll definitely double check on that. One of the things I was going to share earlier is one of the levels of care that used to be in place before an unbundling, I think in 2007, was a subacute level of care, which I think meets the need that you're talking about, which was kind of an in-between group homes, but before PRTFs, where it's a less restrictive area, but still focusing on wraparound services. So we have started artificially putting that into place with 2 provider groups that we're working with. DFACS is paying for the room board component, we're paying for the treatment component. So I think that would fit part of the bill if we can expand that across the state. That gives you trained clinicians in a less restrictive area, a place that they can really practice their skills before they go into a foster home.
Senator Jackson,
12.
12.
Thank you, Mr. Chairman. So just piggybacking a bit on Madam Chairman's question about how do you determine how well you're doing? I'm curious, what is your process for a young child who is not progressing? Let's say that they've been experiencing suicidal thoughts and they're getting treatment, but they're not advancing, they're not getting better. What is your process for that? So I know you gave us a great example of there being a placement problem and say you're saying we can't just keep people in a hospital just because they don't have a place to go. That's not there. I get that. But what is your process for any child that's under care who is not advancing, who has expressed that they're having problems and the doctors, the clinicians say this child's not getting better?
You want to speak to that?
So I'll speak specifically in regards to PRTF. That's kind of the big topic. There are different levels at which that could occur. So when you don't have a child that's progressing in a residential facility, what we've got different interventions. One is a consult that I'll do, a peer consultation, which is not a medical necessity review. I always make that very clear. This is not about, denial or approval. Just to talk to the physician or the nurse practitioner or the therapist, whoever they set me up with, in terms of what's going on with the kid, just to give me some clinical insight, and we'll problem solve. I mean, I've sent over, information. They've talked to me. We'll kind of dig in the case and try to figure out what's going on with them. Sometimes these facilities are at the point where they're like, well, we need to do a lateral transfer. We can't serve them here anymore. They just, we need to, send them somewhere else. Well, where somewhere else, who's going to take them? They start to get to wit's end. Our case managers, they do, a lot of coordination when these kids are in the facilities, bringing all the stakeholders to the table to say, okay, this child is not progressing, or they're regressing because there is no place for them to go. The parent has abandoned them and said, they can't come home, or we're saying there's no place in the community that's going to accept them. So any gains they've made, now they're starting to regress. And so we will get everyone at the table and just try to problem solve and dig through. We also have other internal meetings where, we'll bring in physicians, clinicians from other teams, outside of our team, just to kind of new set of eyes to say, okay, how else can we look at this case? How else can we problem solve for it? There is a lot of energy that goes into, these very complex cases that I guess isn't obvious. It's a lot of internal work, but it's absolutely happening. And also, just as a standard, for an example, we have daily rounds. So these cases are brought to me on a daily basis in terms of, looking at whether it's authorizations or looking at complexity and things like that. So we are actually talking about these cases. We're not just looking at paper and saying yay or nay.
Thank you, Doctor. So we got we're at 5 o'clock, and Senator Orrock, I'm going to let you two decide who gets the last question.
Okay, I'll just use my seniority.
Gracious of you. Gracious.
Well, right, in the spirit of being gracious, I'd like you to speak to the denials. We heard from the attorney, Brian Pedersen, about the denials for medical treatment, which are pretty straightforward. And the EPSDT screenings and those sorts of things. But what's the basis for those numbers of denials that we heard from the attorney who's having to file appeal after appeal after appeal to pierce through your all's denial rate and speak specifically to the medical treatment denials that he brought before us.
So I think to reiterate part of what Dr. Sewell says, with our prior authorization process, it really comes down to what is submitted first, at the first time that a request is sent in. The more minimally information, the harder it is for us to make medical necessity meet. But we have a peer review process in order to gather that information. So I think, this comes from, our behavioral health team, including Dr. Sewell, has done numerous trainings with providers and are able to do that at the request of anybody that asks, because our process is consistent with the other CMOs. We all use the same form in the same platform to submit prior auth or request prior auth requests from providers. So we can train providers on what kind of information we're looking for in each section. But if there's not information in there, it's hard to then make a medical necessity determination of the need of that service.
Well, is there another step where you can say, we need some more information?
Yes.
Instead of just sending a denial?
Yes, so
That's
we
what
do
you're
that.
doing. Sounds like you're just sending a denial.
We send a denial with a
But you're
peer
on-
review request. So
Yeah.
they can contact us within a certain time frame to either provide that information if they choose to do so.
But I think that there needs to be, we'll drill down
Thank
on
you.
this question.
Thank you on that,
Why is the
Senator.
denial
All right. Thank
appropriate?
you all for being here. Really appreciate that. Thank you so much. We're gonna have a little bit of a brief by my partner here.
Yeah, so I want to thank everybody that stuck it out through this sort of really difficult meeting. And I want to thank all our speakers, and I want to thank Lieutenant Governor for raising the profile of this issue. And I think one thing that we have accomplished today is to raise awareness and to make sure that everybody understands this is a front burner issue. These kids didn't ask for this, and they should be going to the front of the line, however we can get them there. I don't think there's any disagreement about that. We've talked about some pretty specific solutions, not everything, but we've talked about reimbursement for very specific CPT codes, for example, for autism diagnosis. We've talked about not requiring prior authorization for kids, foster kids in crisis that are trying to get emergency services. We've talked about getting more information about out-of-state PRTFs that are prioritizing out-of-state kids for whatever reason. That seems like it needs to be dug into some more. We've talked about other insurance ways maybe to improve access to care. We've talked about data sharing, and I think the data sharing piece is super important. We passed legislation on that. We've started down the path of an all-payer claims database. We've got the Office of Health Strategy and Coordination that is gathering data, and hopefully that is going to evolve into a very robust and important data sharing tool for us in the state. The placement issue, I don't think we have figured out a solution for that yet, but we've got some ideas about that. Senator Tillery back there is an idea machine, and we'll be talking more about do we need subacute option or what exactly would fit. We've got several bills from the Department of Human Services that should be helpful. And what we really need is everyone working together. We need all our agencies working together because there's so much overlap between the different agencies on these issues that we really need good communication happening. So I think Chairman Watson, I promise that we're going to continue this conversation and appreciate all the input. We've kind of run out of time for today, but hopefully everyone here has a better understanding of the issue now. So thanks to all of you for coming, and we're adjourned.
Thank you. Meeting's adjourned.